Today, I have the great honor of introducing you to Christian Hardahl, who is EMEA Healthcare Lead at SAS. And he'll speak to us about AI Hospital, how interoperability and precision health will redefine patient care. Christian, you are very welcome.
Thank you for having me, Patricia. It's a real honor to follow the great lineup you have in this series. So thank you.
We are looking forward to speaking to you. Your title's fantastic. And I suppose before we delve into that, Christian, your current job title, you're healthcare leader at Europe, Middle East, and Asia at SAS, or in Africa at SAS. Could you start by telling our audience maybe a little about you and your career to date, please?
Yes, certainly. So I hold a master's degree in biomedical engineering and health informatics. So I actually began my professional career at SAS in the healthcare space more than 15 years ago and never left the company. Initially, I was working in the consulting department, implementing our software with the healthcare customers. So doing healthcare data and analytics solutions in Nordic hospital systems. So this means that I have seen most maturity stages during the last 15 years when it comes to data and analytics and how tricky those journeys with data, BI and AI can be, even for organizations with really good intentions.
Okay.
So after some years in consulting, I moved into the practice of this EMEA and Asia Pacific role, focusing much more on the industry advisory on how healthcare organization they should run health technology transformations, research environments, innovations, and data analytics projects. So basically, I see my journey has been driven by a passion for improving patient outcomes through innovative solutions. I love technology and I love seeing what I do get an impact on improving other people's life. And that can be patients, healthcare professionals, or even back office workers. So yeah, and I'm so lucky I get
Sounds
to do that every
sounds
day.
fun. Sounds fantastic, and I'm sure our audience will have you've opened up the door for lots of questions there. But I suppose maybe just so that our audience is fully familiar, what about SAS? Who are they? Maybe you can tell us a little bit about what that company does.
Yeah, so we are a global leader in analytics and data, and has been working in this space for more than 49 years now. Next year is our 50 years birthday. We operate across multiple industries, including healthcare, life science, finance and insurance, and government, of course, and providing analytics platforms and industry-specific solutions that enables our customers to uncover insights and predict future trends, optimize operations and revenue, and things like that. And when it comes to healthcare, we have a dedicated practice for healthcare and life sciences, which means that we have the ability to go beyond the technology discussions and operate on a more partnership level with our customers. And in healthcare specifically, we help our customers use data and analytics to improve patient outcomes, optimize operations, and drive innovations in care delivery, just to mention a few of the topics.
Yeah, brilliant. And so now I have to come on to your talk title because it's so intriguing. AI Hospital. Maybe you could paint us a picture of what you mean by this. And I suppose a big question, is this current reality anywhere in the world?
Yeah, that's a really good question. So the concept of an AI hospital is, to me, fascinating. It's really about using the data and the technology and automation in the entire organization. I'm imagining a healthcare facility that is driven by optimizing every aspects of the patient care, from the diagnostics process to the treatment plans to the administrative task, resource management through optimized and fair scheduling. That there's so many and endless opportunities. But to accomplish this, we need to start with securing the data and ensuring the interoperability between all the healthcare systems. Even some of our European healthcare systems are looking more at holistic healthcare. So that's even more broad than just the healthcare system. So interoperability is a key if we want to actually build this vision in the future.
And when you say interoperability, Christian, just so our audience is fully familiar, what do you mean?
So if we really simple, it means that all the systems that we implement in the IT landscape should be able to communicate with each other with a language that they understand and that we can all get access to and use those data to other things like research that you do at UCD. So that's what it really means, that we have a common language and understanding of each of the data that we put into the systems. So that's a huge task. That's something we're working on in all of these technology companies, and also on a more like regulated state as well.
Okay. There's so many questions coming in for you, and actually the first question is the, I suppose we're based in Ireland, you're based in Denmark. I should have said that at the start.
Yeah.
So similar population, actually similar healthcare spend, but Denmark is one of the most digitally advanced healthcare systems in Europe, and maybe you can tell our audience a little bit about that, because they may not be familiar with what you've achieved as a country.
Yeah, so I think in general, the Nordic countries have a long tradition of being digitalized, not only in healthcare, but in all the public and government institutions. So we benefit from that. We have our social security number, so we can track ourselves in all the systems and connect those. We have lots of quality registries, etc., that we can use for research. And when it comes to the use of EMR systems in healthcare and lab systems and the various systems that we use, we also have a long tradition of having access to those in clinical data warehouses. So for someone like me that lives from healthcare data and build things on top of that, it has been a really good place to spend the last 15 years. And we have built some incredible things with our customers across the Nordics countries. Some of the examples in Denmark goes from early detection of cancer to doing one of the most impressive AI projects I've been part of, with the research of more than 9,000 patients with 240 biomarkers. You're doing some biomarker work yourself. So imagine working with 240 of those and find into something usable with AI. That's been quite some incredible tasks that we have been faced and
so this project that encompasses the 240 biomarkers, that's in emergency care. Maybe you could walk us through that project. How would you use AI to analyze them? What does it mean? I mean, you talked a good bit about patient outcomes and helping clinicians, helping patients at the start. Like, what has this done?
So the interesting part is that we actually had to get the data. So we come from a very data-rich country, as you mentioned. But for this project, because we were doing 240 biomarkers per patient in the acute department, we had to start from scratch, building that cohort of patients and doing those biomarkers on the blood samples. So we selected those 9,000 patients from acute departments, got the data, combined it with some of the vital parameters that is also registered within the first 60 minutes of an acute admission. And then we collect that data. The tubes are being sent, so the blood samples are being sent through a tube system to the laboratory, and that laboratory has been optimized from being full of people to now being driven by robots. So everything is driving around in small cars in the laboratory and to all the different machines and being analyzed. And when the different biomarkers are analyzed and are ready with the results, we pick them up with our technology in real time. And then we can, when I have a full sample on you, for example, Patricia, when I have for all 240 biomarkers, I could then apply it to the AI, and then we could return a risk assessment on your profile of data for 14 different diagnoses and 5 outcomes. That is something we did on the 240 biomarkers, but that's not sustainable from a cost point of view.
No,
So we actually,
no, that's very expensive to keep testing 240 biomarkers. Yeah, I get
yeah,
it.
some of them are quite cheap, but some of them are
Okay.
also very expensive. But we reduced that to 60 biomarkers instead of 240, and a price point that is something that you can implement. And we are now going to test that in an RCT study
Wow.
in this after summer. So we are really looking forward to this. We have some incredible results that has been published as well, so you can have a link to that.
We just popped that in, actually.
Okay.
It
Yes.
just got popped in the chat, so thank you. So if anybody is interested, this paper that you've been part of, Christian, that's been published, and now you're going for an RCT study. So now you're going to basically independently verify this. So did you say so the data was on 9,000 patients, and now what is the projected amount of patients in your RCT study?
Yeah, so that will be between 16 and 80,000. So we need, every second patient won't get the AI score. So we need the same amount that we had in the development phase to make sure we have some robust results. But it will all be, so we built the entire platform to do this live. So that's what we're going to do in the RCT. So it will be like running in production, right? But only every second patient will get the AI results. So we have a chance to actually test what is the area on the curve for the doctor and what is the area on the curve for the machines.
And just so we're clear, I suppose our audience is clear. So the outcome, the best, that saves clinical time, that saves people time. It's more efficient, but for the patient, what's their outcome? What's good for them?
Yeah, so we should really reduce the mortality in the hospital, which is that can also be seen in the paper what the mortality rate is, but it is quite high. Of course, it's an acute department. That is a risk when you go there, but also things like sepsis, patients ending up in ICU. We should see those rates fall. Readmission rates should fall.
Because you're catching them early, Christian. So you're catching the sepsis early, you're catching the disease. Yeah, okay. You mentioned 14 diseases, did you?
Yeah, 14 diseases, including all the big infection areas.
Okay.
And even we have an algorithm for safe discharge of patients within 60 minutes. And that basically means that you can discharge the patient knowing that this patient will not be readmitted. The patient will not die in 7 days or 30 days. So that it should really be seen as a really good friend to the doctor. Yeah. But of course, there's still it's only 14 diagnoses. We have a lot of ICD-10 codes, so there's a lot we don't cover, which the doctors, of course, needs to think of. So they really need to know and be trained in how to use these results and how to do the clinical evaluation when they have these inputs. But even with the 14 diagnoses, we cover almost 45-50% of all diagnoses in the acute department.
That's incredible. And we have a great question actually in from one of our listeners, Niamh Whelan. What ethical considerations should be taken into account when dealing with patients who are reluctant to accept AI involvement in their care?
Yeah, that's a really good question. So
yes,
in SAS, we do a lot within trustworthy AI, and we do a lot of making our models transparent. And even in this project that I just described, the doctors actually have an opportunity to go from. So basically, the result that we are returning is like a biomarker result. So like they're used to see the biomarkers with a percentage. But they can actually go from that level into the specific algorithms and see what variables for the specific patients have the most impact for that patients to kind of build up the interoperability in the solution. And that should really give the physicians the trust in the models, and also the ability to discard results if they don't agree with their own clinical knowledge. For the patients themselves, I'm not of course, it can have an impact on what they will get at the end of the diagnostic process, but it should really help accelerate the entire treatment plan. Even just having all of these results within 60 minutes, that's not something you have today. We see a reduction in the number of times that they will have blood samples drawn. They will only get that once. You know, if you're doing a clinical evaluation, you might have multiple tests done. You will only get that once because you're doing everything up front. So there's a lot of benefits for patients with this system, but of course you need to consider all the ethics behind.
Yeah.
And,
of course, and that's the fundamental part of it. But is that so? Just two short questions because we're kind of running out of time. But is that in use in emergency departments? Is that particular algorithm in use?
Yeah, so not right now because we're waiting for the RCT. So
okay,
I think that's another good thing when we're talking the ethics. That's the approach we're taking here, where we don't just. So we have some really promising results that you can read about in the article. The algorithms are performing really well on the cohort we have. But we need that RCT to make sure that we also get the outcomes that we expect and hope for. Because if the models are not better than what they do today, we don't need it. We already built the automation, so we get a lot of benefits from the automation already. But the algorithms and the decision support that they provide to the clinicians, that should really help them to do better diagnostics for the patients and have faster treatment plans. And we should see that in the outcomes for readmission rates, for mortality rates, for ICU rates. And that should really be the benchmark. So if we don't see that from the RCT study, I don't think we will see any of the models in production.
Yeah,
it might also show that we only need to put 5 of them into production. We don't know that yet.
Yeah, I get you. And just we've completely almost run out of time, but I just want to bring you back to something, you know, to your title now, this AI hospital, and what you said about SaaS democratizing AI and working very closely with partners. I suppose, what does the future look like? You know, when will we see this AI hospital, you know, give us a vision of what you see, your optimistic view, I suppose, of the future?
Yeah, so I see so much good work around the world, organizations doing lots of great things. I also see a lot of organizations starting that journey, so the maturity is widespread. I'm not sure we're going to see like a fully operatable AI hospital. I'm not sure we want that. We would probably like the humans in the loop, and I think we should only use AI when it makes sense, when machines accelerates much better than humans, and that is when you have huge amounts of data, when you have huge amounts of information, when you need robustness in decision making. They will do the same decision every time based on the way they are trained, of course, and they will deliver day and night, 24/7. So there are some really incredible things about models and automation, and also when we talk AI agents and those kind of things. I think we will see much more of that, but like a fully operatable AI hospital, that might be a bit far out in the future, because I think we would still like that human touch and that caveat we bring into the hospital sphere.
I think you know, you've hit the nail on the head. It's all about human, as I say, human in the loop, and that's why our series is called Human Health Impact Technology. Thank you so much, Christian. Unfortunately, we are completely out of time, so sincere apologies to all of those whose questions I didn't get to. I just wanted to take this opportunity to say a formally huge thank you to Christian for the most fascinating discussion today. Thanks, Christian.
Thank you, Patricia.
And thank you to everyone for joining in. Please do check out our list of upcoming speakers on our website, and see you all very soon on the next UCD Hit. Thank you so much, Christian. Take care. Thanks. Bye.